You're listening to the Yoga Medicine Podcast. I'm your host, Tiffany Cruikshank. Our podcast brings you information and resources to enhance the therapeutic effects of your practice based on a deeper understanding of anatomy, physiology, and the integration of modern science and research with traditional practices and experiences. Join me and my co-hosts, Rachel Land and Katja Bartsch, as we dive into all things yoga, research, and wellness. Welcome back. Excited to be back to talk more about the fascia and to talk about pain. We're going to dive a little deeper. We started a little bit of this conversation in episode 19, so that might be another one you want to listen to if you're interested in fascia and pain. But we're going to talk about fascia, a type of connective tissue. Really, it's this tissue that surrounds and encases literally every part of our body. So a lot of implications. And we talk a lot about fascia on this podcast. So you can find a lot of other episodes where we dig deeper into different aspects of fascia. But in this one, we're going to dive a little deeper into the implications of fascia in pain and talk about some implications both in our life and in yoga practice, and look at some of the research and what it suggests to us at this point. Is such an interesting point of attention that's getting a lot more spotlight now. And luckily, as we start to learn more about it and start to learn about how we can influence and interact with this intelligent, far-reaching landscape of connective tissue or fascia in the body that has so many different implications. So we're going to dive into it. We are going to also mention some of those episodes as we go through so that we don't have to go into every rabbit hole, because there's a lot of information here, but we want to give you a bigger picture view of a bunch of different implications for pain. So excited to be back.
Yeah, me too. And excited for this one too, because also we're going to talk about kind of one specific type of pain, which may be obvious because it's termed myofascial pain. So it's kind of clear that it might have something to do with the fascia, but it's also not very obvious as well because it's still rather poorly characterized and not fully understood, despite the fact that we think about 30% of people who experience musculoskeletal pain have some degree of myofascial pain involved probably as well. But yeah, that's kind of a fascia-specific type of pain, maybe kind of obvious, but also not.
Yeah, so wide-reaching implications in the pain world. And I think if you're a human, at some point you will probably experience some form of this. And as a yoga teacher, we're definitely working with us a lot, as you'll see as we talk about it a little bit more. So, where do you want to start? I'll let you choose.
Okay. I would say let's dive right into the myofascial pain, or maybe one more generalized note up front. I think pain is very complicated. I think that needs to be acknowledged before we dive into this. And my personal understanding of pain is really fragmented. I'm studying it quite a bit, or quite some, but it's very, very fragmented. I do know, and that has been in the research for the last couple of years, that fascia is generally being a bit more acknowledged as a pain generator, or has been over the last couple of years. But of course, and I want to say that up front, there are many, many different mechanisms behind pain, many aspects of pain. So a couple of years ago, the focus in pain research was maybe more on mechanical aspects, with which muscles do play a role, with postural aspects play a role. And these days, maybe it's more the neurogenic aspects of pain and the inflammatory aspects of pain, immune system related aspects of pain that are being more discussed, and also a little bit the fascia. And I just want to acknowledge that and note that we will talk about one aspect, one puzzle piece of pain. We're not aiming to rewrite pain science history or not acknowledge what else is out there. I think that's important whenever we talk
Right.
about pain.
Yeah, and I feel like we talk about pain so much in yoga medicine and our teacher trainings, whether it's the nervous system training or the orthopedic trainings. Pain is such a big reason why people often come to yoga, therapeutically at least. And so there is a lot more to this conversation. And I was trying to look and see. I feel like we've done an episode on pain before, but if not, we'll definitely will need to, because there is so much to talk about, and we've got courses on it and classes on it on our practice site. So, but let's look at the fascial implications because, as you and I were talking about before we started, there's a lot of implications and a lot more attention to fascia as a pain generator and looking at its implications, as you said, 30% um uh of what tell me what was exactly was the word you used? 30% of all myofascial pain.
We do think that an estimated 30% of patients who are experiencing chronic musculoskeletal pain
Yeah.
also experience some form of myofascial pain. And maybe it becomes more clear when we specify real quick what myofascial pain is, despite we don't have a full specification of it. So it's typically chronic pain involving trigger points, myofascial trigger points, and the fact that you're listening to a yoga medicine podcast and you're listening to Tiffany also kind of implies almost that you may have heard of myofascial trigger points. It's definitely a term that has been discussed over decades, may still not be fully understood, but what we can say it's that those are typically spots that are tender to the touch that can be palpated. They're kind of indurated nodules of tissues, and they can lead to pain, spontaneous pain. So there are active phases of myofascial pain where those myofascial trigger points can lead to spontaneous outbursts of pain, which then can also lead to reduced range of motion, and that can all be a part of that. And there are also latent phases of myofascial pain when range of motion might still be decreased and those areas might still be palpable, so we can still feel them maybe, but they may not lead to those spontaneous outbursts of pain. It's a very quick and very generalized version of this. Maybe you want to add to that a little bit.
Yeah, I love that you bring up trigger points because I feel like it's always a source of question, and we talk about them a lot in our trainings. And this idea of both active and latent phases is really interesting too, because anyone who's done like a myofascial release class or workshop with us or with anyone, you'll experience some of those tender areas that could be more of what we think of as these latent trigger points that aren't necessarily causing any pain or dysfunction other than just tenderness as you're rolling on them potentially. But this idea that as they become active, potentially causing pain, limited range of motion, referral pain as well, which I think is always really interesting and limiting to our lives, to our experience, our pleasant experience of the world within our bodies. And a really interesting area to work with, I think, as yoga teachers, um, if you've used myofascial release or not, I think anyone who's used it has experienced how potent it can be along with our yoga practices and how powerful it can be for symptomatic relief. And potentially, I think there's more research to be done here. You and I, we won't go down this rabbit hole, but potentially some long-term implications of that as well over time, maybe. But trigger points, a really interesting one to work with pain and really just those tender spots that we're looking at.
Yeah, and if you have done myofascial release before, you probably know what we're talking about or what we mean, because many of us do experience pain like that, as we mentioned before with those numbers. What is not as clear though is really the mechanism behind that, or different mechanisms behind that. There are potential mechanisms, and as always with pain, it's complex, so it's probably a mix of things, a mix of mechanisms that play into this here, but it is thought that it could be some sort of so nerve involvement, so some changes. There are inflammatory aspects. So if we have chronic inflammation in a certain area in the body, that will set up the body to be pro-nociceptive. So it might be kind of easier for the body to receive nociceptive signals, so pain signals from the tissues. It can make the tissue or the receptors of those nerve endings of those nociceptors that pick up the pain signals more sensitive also. So all kinds of things related to nerve and inflammation. It could also be that the muscle is a bit hyper excited, hyper excitable in those areas. And also, we do think that maybe the amount of blood flowing through those areas and then also of oxygen is reduced. And that could also, yeah, lead to that sensation of trigger point pain. But it is still not fully understood. There are a couple of research groups out there. And one problem that we have, why it's not as fully researched yet or fully understood yet, is that the diagnosis of myofascial trigger points is not as clear either. So I said we touch those areas, we palpate them, and there are some studies that show that it's quite reliable to do that with touch, but there are also other studies that show that the touch or palpation of those trigger points might be somewhat subjective. So there is no objective diagnostic tool yet. There are some that might be appropriate or available, but we don't have the full protocols yet to really say this is for sure, without discussion, a myofascial trigger point. And that is kind of one aspect why we are where we are in the research. So we know that there are trigger points, we can feel them. Some studies show we can touch and feel them, but we cannot image them, for instance, so that the whole medical world recognizes them.
That's
That's
such an
a
important point too. I feel
Mhm.
like so many people, I feel these questions always come up in the trainings, and I'm really excited because we're going to be running a whole week of myofascial training in Spain this year, in May, and I'm sure we'll run it again. But it's just it's a question that often comes up about the trigger points. I find them to be a very useful tool that I've used for 20 years with my patients and for a long time with yoga students and our teacher trainers. But there always are those questions, and it is a hard one because we can't really put a scientific lens to it as easily. And basically, what we're talking about are, trigger points being part of these myofascial pain syndromes, and one that's most commonly referenced. And we're just talking about some of the common mechanisms, which are a lot, right? We talked about neurogenic, inflammation, hypersensitivity, peripheral sensitization, blood flow changes, oxygen changes to the tissues, hyperexcitability, acidosis. I mean, there's a lot of different things that can cause it. So it's not like a clear pathway. It's not easy to, there's not a clear way to diagnose. And so, but I think clinicians and people who use this in their practice of, and it's used in a lot of different healthcare lenses, know that it can be a very powerful way to work. And I think, at yoga medicine, it's always really important to us. The research is equally important to our experience. So this one definitely stands the test of time and experience that we can say. Yeah.
Yeah, and talking about mechanisms in research is always one thing, but knowing that there is clinical effectiveness is something else, and we have, I think, a long-standing experience now with myofascial trigger points. They're very well established in the clinical practice, and there is a lot of research on this actually. But when we want to understand the nitty-gritty details of what
Mhm.
exactly is happening there, that's where it gets really tough. And that's what I was referring to with the imaging and those different pathways, how they come to life. So that was not questioning or not acknowledging that they're there. That's, I think, kind of clear, but it's kind of more complicated to look at the specific mechanisms. And that's where it gets tricky. And I want to be upfront where we are with that as well. But
Exactly.
so that's all complicated. And some of it is still in the making, but it's termed myofascial pain. And we can say that we definitely assume that fascia plays a huge role in this syndrome, in this pain syndrome. And that's why we're here today. So we want to chat what influence the fascia may have, because all those different mechanisms, even if we cannot quantify or specify them fully yet, they have to happen somewhere, right? They have to originate somewhere. This pain is not happening in a vacuum, and a nerve does not live in a vacuum. An inflammation is not taking place in a vacuum in the body, but it's happening probably somewhere in the extracellular matrix, somewhere in our fascial tissues. And that's where we want to, yeah, dive into a bit deeper today and kind of highlight some of the more kind of the bigger picture questions how fascia can be involved here.
Yeah, and so just to kind of cut to the end point here, I guess a little preface is we're going to kind of go in two different directions here. You know, one being the mobility of the fascia, and the second being, you know, looking at fascia as a sensory organ. And those two kind of main components being a really big part of what we see in the implications of pain. So, why don't we start with fascia mobility? Because there's also some implications too within the mechanisms of, you know, fascia of the uh patho you know, genesis or potential pathophysiological mechanisms of the myofascial trigger points and pain syndromes.
Yeah. So when we talk about mobility, what we mean is kind of more a mechanical lens. So how well is fascia moving more on a macro level? So from a big picture view, maybe. And when we look at myofascial pain or fascia in that way, we look at, for instance, different layers of tissues. And fascia is layered into the body. So you have just doing this here on the screen, you have your skin, then there's the more superficial fascial layers, then there's deeper fascial layers, then you have muscle layers. And depending on where you are in the body, that gets a bit more complicated. But generally, we have different planes, muscle, skin, but also a fascia, and different tissue layers and also different fascia layers are separated by connective tissue, by fascia that is kind of more loose. We call that areolar connective tissue. So it's not as dense. The collagen, which gives a lot of structure to fascia, is not as dense in there. So it has that ability to let those fascial planes, the fascial tissue layers, glide. I'm gonna say glide past another. You can imagine in the body, they're not really going to glide past another. They're going to move in relationship to each other. But in due to or because of those more loose layers, in some areas that's gonna be easier to move in relation to each other. And in other areas, it's gonna be harder. And that's what we call shear mobility or that slide and glide between the layers. And that can, before we dive maybe into more detail or what can happen there, that already can have huge implications for our yoga practice. Just knowing that there are different fascial planes that move in relation to each other and also in relation to other tissue layers like the muscles or the skin.
And I think just to clarify too, because we talked at the very beginning about connect or fascia as a type of connective tissue that surrounds every part of the body. So every nerve, blood vessel, bone, muscle. Just imagine too that every one of those things, we'll just talk about them generally, is also moving in a slightly different direction. Like even just muscles have slightly different attachment, emotions when we're moving, whatever that movement is. And so this gliding is really important to allow for each of those things in the body, whether we're talking about nerves or muscles, to be able to perform their movements and actions, which is really important for a lot of other reasons. But, you know, I think also just for the visual, imagine too, just so it's not confusing, that each of these, the casing is more of that dense connective tissue or fascia, and then what she's talking about too is a loose connective tissue kind of lining to that, right? And am I, correct me if I'm wrong, but lining to that, which allows for the gliding. So just because I know there's be some people on here who've taken our courses and they'll be like, wait, I thought it was dense connective tissue. That deep fascia, we have that dense connective tissue as the more of the casing, which is thin and fibrous and strong, and then a layer of this loose connective tissue, which allows for the gliding, which is so important and getting a lot more attention these days as well because of all of the implications in pain and other areas as well.
Yeah. And you can easily imagine it's a tricky job for the body to maintain a really good and vital balance between mobility. And with mobility here, I mean how much movement there is between those layers, how much of that, I'm doing quotation marks here in the video, sliding and gliding there is between the layers, and how much stability we want. So we don't want indefinite, infinitive sliding and gliding. We want stability and flexibility in the body always. So that's true for any type of consideration you do in movement. And that's even true for the mobility between fascial planes as well. Because I want to set that up because we're going to talk about some nuances later. But of course, you can imagine that things happen in the body. You can get injured, or you can sit in front of your desk all day and not move those fascial layers in relation to each other. And you can easily imagine that in such scenarios, that those fascial planes get adhered to each other. So they kind of get more sticky to each other because maybe there are cross-links building between the collagen fibers. Those are more of the nerdy comments if you have talked about fascia or have learned about fascia. So just some nerdiness side notes here. So some cross-links, some collagen fibers making connections between each other, kind of prohibiting that slide and glide to some degree. You could have generally more collagen fibers, more collagen density that makes for a more fibrous, for a more dense and sturdy, stiffer tissue. But also there are other components of our fascia, for instance, hyaluronan. If you want to dive deeper into that, we talked about it in episode 67, that enable that slide and glide also. So that's basically sugar molecules that bind water to them. And that water, you can imagine, and the sugar molecule also provide some slide and glide. And then if you don't move, or in certain scenarios, that hyaluronan content and the hyaluronan architecture can influence that movement between tissue layers as well. So there are scenarios where different things happen that kind of limit that range of mobility between the fascial layers. And that were a lot of mechanisms in there already also, but that also has clear clinical or movement implications for practice. I don't know if you want to maybe jump in here and talk about a
Yeah.
yoga practice in that context.
I love it too because I feel like I love thinking of the little fasciocytes, which are these specialized cells that live in this layer here, like the oil can, right? Because and this is, I mean, correct me, I feel like with COVID, my understanding of time has changed a lot, but this is a fairly new, fairly newer, newly recognized cell within the last what 5 years or so. I feel like, but we've looking at these specialized type of cells that live in these gliding layers that actually produce hyaluronic acid or this lubricant for these gliding layers that are also potentially stimulated through movement. And so what we're talking about here are basically two different ways that the mobility between these layers can be um, hindered, and that is through that fibrous collagen matrix changes, whether that's cross links or density, and the lubricant changes. And part of that I think is interesting when it comes to any kind of movement practice, because just any kind of movement will be helpful because that movement between the layers maintains not only the mobility and kind of breaks up the ideas that it helps to kind of break up some of those cross links and stimulate the fasciocytes for the lubricant. Um, and I say that with a little pause because there are a little deeper conversations around breaking up cross links and collagen fibers. But the idea is that as we maintain movement, we can maintain that gliding. And so, really, I think any kind of movement practice can be an important application for what we're talking about within this fascial mobility. And if we're talking about this happening all over, I think the implications are also that, either we're working on areas that need it the most, if there's problem areas or areas that need to be addressed specifically, for whatever reason, pain or athletes, whatever the case might be, or both. Or the fact that we also just need to kind of find different ways to mobilize a lot of the different parts of the body, and that can be more challenging too. And I think sometimes why I really like our weekly lineups where instead of going back to the same practice all the time, we kind of get set in our ways. You get slightly new practices. I really love trying to find movement in different ways, and I know you do too, to kind of work through the different areas and feel into that fascial gliding. That's I think so important, so simple, but
Yeah. I think diversity of movement is such a big one. And I think one thing, it's so important what you're saying, that there's basically those two big buckets of what can happen to the fascial tissues, one more related to the collagen density and the frost connections, maybe, and the other more related to hyaluronan and the water content, maybe. And one thing that gets asked so often, I feel, is what is happening after my practice? Why am I having more mobility? Why am I having more range of motion? Part of it might be because of that slide and glide. There are other nervous system related aspects also, but when we just look at the fascial tissue aspects, the short-term effects probably lie more in the hyaluronan slash hydration water bucket. So the immediate aspects you notice are probably more related to hyaluronan, water, maybe nervous system, and the longer term effects. So if you really stick to your practice and if you do those weekly wellness lineups for a longer time, you can actually expect to change the architecture of your collagen matrix in the fascial tissues so that breaking up that Tiffany was referring to of fascial tissues, we don't no longer think of that way in the research. So we don't think that one manual therapy session or one movement session will break up fascial adhesions and then you're good to go because everything's free. But we do still think that you can reorganize those crosslinks or those denser areas, but over a longer period of time. So you can reorganize the architecture of your fascia over a longer period of time. And the short-term effects are probably more related to the hyaluronan and the water content and the nervous system, which we'll talk in a minute. But
which
yeah,
I
so
just as a side note, I think is so interesting too because there's so much interest in mobility in yoga and in the world, the larger world too. And whether you're more on the passive mobility side of the spectrum of loving yin practices or the more active mobility spectrum. I mean, I think a lot of the mobility practices we do, whether it's active or passive, is really focused. And what I love about what this tells us, and we're talking really generally and loosely, is the diversity can be a really great thing and it doesn't always need to be strategic and targeted. Now, of course, there is a place for those when there is significant, we'll just say scar tissue or crosslinks or collagen fibrosis happening. Yeah, I might need to really focus on a specific area. But as it comes to more maintenance and kind of general movement, we can see a lot of changes happening just through this kind of body wide movement and moving in different ways, the diversity of movement and that immediate change that happens from like maybe a slow flow class that isn't really specific or targeted to any one area, but those mobility changes we see coming from probably more of this fluid later. Those of you who are who have done trainings with us, you're probably familiar with the term thixotropic, but this idea that the connective tissue can actually become more fluid just as we move and kind of like shaking up some kind of thick sludge and it becoming more fluid is kind of that thixotropic effect in the connective tissues that is really interesting. I think we've all experienced that in a flow class and isn't about like mobilizing actively or passively in a yin class, but really is about maintaining this fascial mobility and shearing. And then I'll let you go deeper into the next part that you're about to talk about. But and also we can use this really specifically as well if there is an area we're working with. Those of you who've done the myofascial trainings with us to specifically try and target and shear very specific layers to try and reintroduce that gliding between the layers, which is such an interesting one too that we could talk about as well if we wanted.
yeah, and that's actually that's a perfect segue into how this relates to myofascial pain. Because if you lose that movement between the layers, and if those layers become more adherent to each other, and you lose that mobility between layers, and maybe the overall matrix becomes more cross-linked, so those maybe more collagen related, fibrous aspects of the tissue increase tissue stiffness, that can play into myofascial pain, because we know that those fibrous aspects and that reduced mobility between fascial layers can have an effect on pain. We know that, for instance, for low back pain, so that's not necessarily only related to myofascial pain or trigger points, but also to general low back pain, chronic low back pain. There has been a study which we also, in that pain episode that we mentioned earlier, or also go to or discuss. So if you're interested in that, hop back to episode 19. But we also think that in myofascial pain, in trigger points, there is an increased stiffness, which we can actually palpate. And also there is less of that mobility between the layers, and there's less of that shear, less of that slide and glide between the layers. So if you can use your movement practice to increase that shear mobility, that slide and glide between the layers, that could be beneficial. So that's kind of one major takeaway, that just the mobility between tissue layers and also the tissue stiffness in general play into, or can play into, that myofascial pain. So that's one lever or one angle on how you may or could work with that myofascial release movement. They could play into that myofascial mobility as it relates to myofascial pain.
Love that. And uh, just because I was mentioning as well, I'll just kind of plant a little seed for people who are listening, because I hate I hate being like, teaser and then nothing. But we can do shearing with MFR, because if you just have a basic understanding of the fascia, we know that that superficial layer attaches to the skin. So by kind of pinning down the tissue, the skin layer with a ball, and then moving a nearby joint, the idea is that we're trying to force those layers, the superficial and deep layers, to glide past each other there. And so we can use that in a lot of different ways, but it can be a really great way to introduce that movement between layers. And in my experience, for people who have issues stemming from that, it can give pretty immediate results, though, there is an overtime effect as well, usually. So I think my fascia release is such a great one, because it gets easy buy-in. People usually get really quick symptom changes from the trigger point work that we talked about before, and the shearing. There's so many different effects that are happening. It's easy to get people to continue to do it, and then, like you said, we get the reorganization that happens over the long term, as well as those acute changes that can happen and really give some positive feedback.
Yeah. So, on the shearing in general, there's also a lot of focus in the research actually right now, how to measure that and how to maybe also induce it, because myofascial release might be one way to induce it, and then other ways as well. So, many things to think about in our movement practice. Myofascial release certainly is a great one. And we also promised you not only to relate that fascial mobility to myofascial pain, because that was, you were able to see that coming now, how we set it up, talking about shear motion between layers and how that's a good thing if that's happening in a certain degree. But we also kind of teased you already, or mentioned that there might be different scenarios in the body. So there might be people who have more of a generalized hypomobility in general. And there are people who may tend towards a more generalized hypermobility. And that could also relate to the mobility on a fascial level, so between the fascial layers potentially. And that could also play into myofascial pain. So, two examples, or one example for each, maybe. Generalized hypomobility, so less movement overall, less mobility, joint mobility in the body. That can be observed oftentimes in diabetes, for instance. So people who have diabetes may have less overall mobility in their body, in their connective tissues, and they may also be predisposed to a reduced mobility between those fascial layers, so less of that shear strain, or less of that shear mobility, let me say that. And that could also, of course, then also set them up for playing into their myofascial pain as well. So we talked about why movement is important between the layers. If you don't have that movement, kind of obvious. And on the other hand side of that, maybe spectrum, we have people who overall maybe have more mobility in their body. And you may have heard about Ehlers-Danlos syndrome or generally of the hypermobility spectrum disorders, which are characterized by, for instance, an increased joint mobility. Also, the skin is typically a bit more extensible, and all those things. So people tend to be more hypermobile. A lot of other things happening as well. But when you have a generalized hypermobility, that also sets you up potentially for more mobility between fascial layers. And it can be said that people who have either Ehlers-Danlos syndrome or hypermobility spectrum disorders, they generally have higher rates of musculoskeletal pain, specifically in the back area and in the big joints. That's where they are experiencing them the most, also to injury. And it is thought that myofascial pain is particularly common in people with those hypermobility spectrum disorders. But it's again hard to really quantify that definitively because of the lack of imaging methods that we experience right now. So we don't have the objective measures for that. But we think that people who have, I'm going to say too much in quotation marks, too much mobility, um, do not hit that optimal balance between the stability and mobility between those fascial planes. And that could then also play into their myofascial pain as well. So it's, as always, about the balance.
Mm. And so what I'm hearing from you, I think this part's really interesting, really piques my interest. But what I'm hearing from you is that whether there's too much or too little, just generalized mobility, is that it's also impacting the mobility of the fascia. Both of them are decreasing the mobility of that fascial gliding.
That's a hypothesis. It's not, we don't have like 1,000 systematic reviews to back that up, but that is the thought.
It's so interesting. And then I saw a note too that is hyperthyroid or hypothyroidism included in that hypomobility?
That is included. Yeah, that's one example that is also thought to potentially set you up for a reduced mobility between fascial layers. But again, as we're still developing ways to, for instance, image that shearing ability between fascial planes, I am very sure that there is not a incredible amount of different studies who have looked at this in detail in different groups.
Yeah.
It's more of a going hypothesis, which seems likely, which we could explain easily, or which would make sense.
Well, it's so interesting because I think, diabetes and hypothyroid, both living in that hypomobility category that we're talking about is influencing fascial mobility and limiting fascial mobility, both super common. Hypothyroid runs in my family. It's something that I've dealt with. And I'm assuming too, a lot like hypertension and a lot of the, contraindications in yoga for hypertension, really more associated with people who are untreated, which is almost no one who, if you know you're hypothyroid, you're probably doing something on the spectrum of natural to pharmaceutical, something to treat that and watching your levels to make sure they stay right. Same thing like with the hypertension one as well. So, usually we talk about contraindications or implications from that. Those are neutralized once it's treated, which I'm assuming would be same with diabetes, and, if that was treated though, they wouldn't be probably considered diabetic anymore. But for type 2 diabetes, of course. Um, so really interesting because I do think those are two really big populations: diabetes, hypothyroid, something that's personal for me. And then now we're getting so much more information around hypermobility spectrum disorders and those also becoming more common than, probably just because we're becoming more aware of it and able to diagnose it better. Who knows? There's a lot of different opinions on that. But interesting, I think, too, that both of these, whether, it's hypo or hypermobility, is causing less of that gliding between these fascial layers. And it totally makes sense to me as well. So, lots of implications again for the tools that we would use to try and target some of that. And I think, again, like you said, there's a lot more to learn about hypermobility disorders. But what it does tell us is that if we were to do myofascial release, it wouldn't be about acquiring range of motion, as we know, because there's not a lack of range of motion in hypermobility disorders, but it can potentially be interesting not only for regulating pain, since potentially there's a connection to myofascial pain in these hypermobility disorders, which is definitely what I've seen with a lot of hypermobility patients and clients. Yeah, it's definitely associated with a lot of musculoskeletal pain and myofascial pain. And but also looking at this gliding between the fascial layers, because I think we tend to really, those who do myofascial work, we tend to really think about restoring that gliding for lack of mobility, lack of range of motion. But I think this becomes really interesting because it can happen also potentially, and again, we don't really know, the jury's still out, but starting to kinda get a sense that maybe it also is helpful for these hypermobility disorders. Correct me if I'm wrong on any of that.
Yeah, I'm gonna say yeah, and
And go.
yes, and
Yes.
so yes, and I do think that increasing shear mobility between fascial planes will probably also play into range of motion. So I do think those are not completely separate concepts.
Yeah.
And also one more thing, people who do have a generalized hypermobility syndrome of sorts or disorder of sorts, it's not uncommon that they generally have more mobility in their body and also between fascial planes, but they may have certain areas in their body where they do in fact have hypomobility, so less movement, because maybe they have scarred or injured their tissues because they were so mobile in some areas before, or the body just holds on to certain areas a little bit more because it notices that it has to create some stability. But mainly we're talking about those micro injuries that might have occurred for these people. And so even if you have a hypermobility spectrum disorder, there may be parts in your body where you do not have an intense amount of slide and glide between the layers or mobility in general. So even within one body, we can have both.
Yeah. Yes, I mean, I think I that's definitely my experience as well, and I think, I guess my point was that I think if you approach the MFR, with different intentions, you will approach it differently, meaning that if I approach it with range of motion in mind, I'm going to approach those tissues and work with them a little differently than if I'm going to probably work with them a little bit more gently and subtly if I'm really just trying to get that gliding. And I know that the two go together, but I guess my point is just, if as you're doing the MFR, I'm not looking to force or instigate range of motion changes, but to support and gently restore that gliding that is natural in the system, which might obviously, I think, need some deeper study and research to look at specifics on application and techniques. But I think for now could just change maybe how we approach it to being a little bit more subtle or nuanced versus, really trying to go in there and
Yes.
create more range of motion. Yeah. So anyway.
Absolutely. And we may stop thinking about just the plane of motion for my forward fold, but we may start thinking more three-dimensionally between those layers to
Mm.
think about that slide and glide in all kinds of movement planes and not just in one where we get more of that forward fold or something like that. So yes, fully agreed there.
Yeah, and I think it really, this kind of brings us to the next one too, is it also instigates this body awareness, which is so important, which we're going to talk about too for hypermobility disorders. But I think it also instigates me as the listener, me as my own teacher. Something so important in yoga medicine and all that we do too is empowering our students to listen and be their own best teacher, because no one knows your body like you do. And I think it draws you into this conversation to not just look at one fascial plane or movement, but to kind of look at the whole and to get curious and not overly attached to, theories or even research sometimes, right? We have to be able to experiment and listen and really feel into that and have some background understanding. I think the background understanding and research and science gives us understanding like, hey, I have hypermobility disorder. So these are some things that I might be aware of, but I'm also still noticing and listening and investigating to see what's most helpful for me, which kind of leads into the second bucket of importance that fascia can play as a pain generator or a source of a tool that we can work with to work with pain. And that is really fascia being a sensory organ. And those of you who studied fascia with us or myofascial release with us are very familiar with this. Fascia is packed full of those sensory receptors, such a neurologically dense tissue that provides such an important important tool that we can work with there. So
Yeah, I think over the years that has probably been one of my highlights of understanding fascia, what role it has in terms of being a sensory organ or related to the nervous system. And we talked about it in that pain episode that we referenced. We also talked about fascia as a sensory organ in general in episode 14. I think that was a really nice one also, if you want to go back to that. To me, still is absolutely fascinating. All the work of my mentor, Robert Schleip, directed in that area is so important and has changed the field so much and what we do in practice as well. So cannot thank him enough. And basically, you already summed it up. I don't think we want to go into all the rabbit holes there because we've talked about it, but fascia is really packed with so many sensors that give you a sense of where you are in space, the proprioception, who generally give you feedback also with aspects like temperature or even being hungry, being thirsty, stuff like that. So all kinds of different signals and also pain. So nociception in general also can stem from the fascial tissues themselves or the nociceptors, so the nerve endings transmitting such signals, are also located and housed in the fascial tissues. So just knowing that has definitely also it enlightened me, I want to say, when it comes to movement work and self exploration, mapping out my own body, and just bringing nervous system and movement and body experience together.
So I think this part's really interesting, and I'm sure we've touched on this in deeper ways in some of the other episodes. But for me, it's just a reminder that, especially when we go and it comes to life, I think a lot when we go and do our cadaver dissections every year or two, and the old school thinking of this connective tissue that we just take out and discard in the buckets as being this filler, but now we have this awareness and understanding of it being a sensory organ, we really think of this as the intelligence that we're taking out. Like we look at the brain and there's this just inherent intelligence that we associate with the brain. But as you start to study and understand the fascia, you start to realize that this is intelligent tissue, even just in that dense sensory innervation, but beyond that, which is more than what we'll talk about now. But a lot of it is in that sensory information. Um, so it's not filler, it is intelligent. And then if you layer on top of that, this understanding that proprioception, which is a sensory awareness, this awareness of where my body is in space, proprioception is competing with nociception, which nociception is ultimately which transmitted into pain potentially. um, that they compete in the spinal cord. So if I'm not collecting enough proprioceptive information, the body will put out a magnifying glass for pain and or for nociceptive information. So, I think this proprioceptive tissue not only gives us, for me, this feeling in my body of body-wide intelligence when I'm practicing, when I'm doing myofascial release, which I think right away changes how you use these practices rather than like beating the tissues up, really trying to enhance the system in some way, whether that be shearing or some other way. But then also just encouraging this body awareness, just the listening. Forget about the mechanical changes we're doing that we've talked about to the fibrous tissue and the fluid content we talked about, but then also just that the listening can become a therapeutic mechanism through that proprioceptive awareness can also influence and regulate pain. So I think just having that awareness as you move through your practice can change everything, and also start to realize like more is not better, but also the simple is powerful, and on and on and on.
I
So
think that is so, so, so important. And it's such a huge part of our practice that also distinguishes us from other movement practices. It's that listening, it's that tuning in. And I think when we talk about proprioception and that tuning in, and then relating it to, for instance, hypermobility syndromes like hypermobility spectrum disorder, or again, Ehlers-Danlos syndrome, this is kind of mind-blowing information. We do now know this info is not there's still a lot of research being done. This info is not crazy new, not crazy old, so it's still rather new, that patients who have these disorders, they oftentimes also have proprioceptive abnormalities. So that info is not being those sensory informations are not being processed as in someone who does not have those disorders. And the fact that you do not have those sensory information relayed normally, I want to say, that can play into your pain cascade as well. So um, it's also one aspect that's not a research aspect, that's more of my own observation. I think that might be one aspect why someone who has hypermobility spectrum disorder may not even get, or is probably not getting the same information from doing a full splits to the brain as someone who's not. So think of it that way, maybe. Um, but we don't fully understand yet why the proprioception is different in these people. So it could be secondary to the increased mobility. So maybe the mobility itself kind of plays with the proprioceptive input and processing. But it could also, in someone who has myofascial pain syndrome, could also interfere kind of with the acuity of that proprioceptive information. So maybe the pain, if you have myofascial pain syndrome as someone who has a hypermobility spectrum disorder, maybe those two inputs kind of interfere with each other, a little bit like you already described. But we do definitely know that people who have hypermobility spectrum disorders or EDS do have changes in their proprioceptive awareness. And if you're one of these people, I think that's a very valuable and important information to know if you haven't known that already.
yeah, and I think again, as it applies to like myofascial practices, self, and when I say that I mean usually self myofascial, if you're doing it on yourself or others applied from someone else. Um, Either way, I think the listening is such a big part of that. The listening, the paying attention allows us to collect more of that sensory information, the like slowing down and feeling into the tissues, whether it's the effects on gliding between the layers or that proprioception. Who knows? There's a lot we still have to figure out, but definitely some implications there. And again, the listening allows us to kind of discern and decide what's going to be helpful, of course.
Yeah, and also I think this teaches us not to spring at the loud screaming of the tissues, but as you're saying, at the nuances too. And this might be harder if you need a bigger mechanical input, a bigger stretch, let's say, to feel that intense feedback. It's probably setting you up for needing, or you have to listen so much harder to get that same feedback, which is very understandable. Um, and just knowing that, I think, maybe makes you more aware of needing to listen to the nuances, which is all
Mm.
of our practice, but maybe even more so in someone who knows that their body will need a much bigger mechanical input before the body gives you that big feedback.
Well, and I think that's where we put together. Like, I do think the science and research is really important to inform the listening, right? And so if I don't know that I have a hypermobility disorder, I might, or I don't have hypermobility, I'm not like super flexible. I might be kind of playing with that edge and looking for a sensation in a stretch in particular, just to talk about it very loosely. But if I know I have Ehlers-Danlos or another hypermobility disorder, I have this, even if I just have a very basic understanding of it, and even if I don't have that, maybe I'm very mobile, like very flexible. I think as I'm going into maybe a stretching posture, I'm also noticing, I think this is part of the philosophy of yoga, is like, do I need more? Can I be content? And then can I stimulate the tissues in another way, knowing that I have hypermobility? Maybe it's working with strength or balance or proprioception through strength or balance or MFR work. You know, there's other inputs I can use that might not be intuitive. Like I think a lot of people who are really flexible or maybe even are on the hypermobility spectrum um, disorder range there, also, there's some feedback, positive feedback we get from stretching that can relieve endorphins and feel good at the time that might not be helpful. So that's where it's like, yes, a lot of it is intuitive listening, but I think it's even better if we can inform it by science and research. However, like you've seen, like you've said, and we've seen on this podcast, research is always limited. Research is always ongoing. And there's always exceptions to research. You're an individual. You're different than the people in the studies potentially. So I think it's really important to have those two. And I think that's a really good example to kind of pairing those two together in a practice as well.
Yes. Yes to all of that. I do think we went into quite a lot of the specifics here and also off some tangents. But I do hope that it became clear that mechanical aspects of the fascial tissues, mobility between fascial layers, and also fascia as a sensory organ, how we perceive ourselves in space. And then also, we didn't talk about it too much today, but how we perceive pain are so many different tangents into pain, but also into well being in general. And I think that it just highlights once again that fascia can be one of those tissues that brings together so many different lenses, or we can look at the body through so many different lenses, and we may land in the fascia again and again because it is a connective tissue, and that's what I hope this episode today conveyed with more of a pain lens. But I do hope that we also had a lot of takeaways that were not only related to pain as well.
Yeah, and I think just to tie up that last little bit on the fascia as a sensory organ, to keep in mind, I mean, we were kind of alluding to this, but it can contribute to a lot of those sensations, whether that's deep pressure with MFR or stretching. There's a lot of sensory awareness, whether even just sitting in meditation and paying attention, this interoceptive capacity, which I think we've talked about on another episode, which is a whole nother topic, whether that's on a sensory level or mechanical level. There's, all these inputs, sensory inputs that are happening in this fascial layer. And I think, pressure and stretching are the obvious ones in yoga, but collecting a lot of information. So, yeah, I think that's a perfect place to tie it all together. Did you have any last little things? No. Okay. um, again, so hopefully this brings together a lot of information again from some other episodes, but really just looking at fascia as a source of pain, definitely something that's attracting a lot of attention in the research world as a pain generator, lots of implications in our practice and our lives for mobility, or let's just say gliding between those fascial layers, proprioceptive awareness, stiffness, hypermobility, hypomobility. And so hopefully that kind of brings to life some ways that you can use it in your own body and explore and experiment. So we hope it's been helpful, and I look forward to our next chat. Katja, thank you.
Me too. Talk soon.
Thanks for listening to Yoga Medicine.
If you like the show, please be sure to subscribe and leave a rating and review on Apple Podcasts or wherever you listen to podcasts. And if you got something out of this episode, please spread the word and share it with a friend. You can find more information, articles, trainings, and classes at yogamedicine.com, or check us out on social media as Yoga Medicine. You can also email us at info@yogamedicine.com. Thank you for being a part of our Yoga Medicine community. We look forward to seeing you again. The content of this podcast is not medical advice and is not meant to replace medical care. Please consult your healthcare provider to determine what is best for your unique healthcare needs.